You don't have to believe a word I say, but to criticize me, you have to have tried these things, and I have done that, all right, on a variety of different things. And so we know what the tissue is, but is it inflammatory or is it mechanical? Two different types, at least two different types.
Few clinicians have done more to sharpen how we diagnose and manage low back pain than Dr. Mark Laslett. Based in New Zealand, Mark is a world recognised spine researcher and specialist clinician whose work on pain mechanisms and diagnostic accuracy tests has influenced guidelines and best practice globally. He has published extensively on the assessment of discogenic and sacroiliac pain and on how to move beyond the label of non-specific low back pain. Mark's blend of rigorous science and decades of clinical wisdom has helped countless practitioners and patients find clarity in one of healthcare's most challenging areas. It's a privilege to welcome Dr. Mark Laslett to the Be Better series.
Yes, so first off, I will just say a big thank you and welcome to Dr. Mark Laslett. So thank you for joining me today.
You're welcome.
Um, so if we get straight into the questions, from your clinical experience, which clinical tests or signs have consistently proven to be the most accurate or useful when identifying the source of low back pain?
Accuracy and useful are not the same thing necessarily. Accuracy has very, very specific um, statistical meaning, and it's measured in terms of sensitivity, specificity, likelihood ratios, and all those statistical things. And that's how we measure accuracy. And it's always considered to be in relationship to a superior standard, which we call a criterion standard. So you have a test that we do in a clinic, and what is the value of testing that test in relation to some superior standard to the test, which is known to make a diagnosis. And it may be that it could be a particular test like a diagnostic block, or it could be something like spinal stenosis, where there's no single test um, that you could say that's the gold standard, if you like, or the what I call a criterion standard. It's a combination of imaging and the history. That's the criterion standard is a combination of things done by an expert who's able to put these things together. And the question is, if you're going to say, is walking distance a good test for spinal stenosis? The answer is not in terms of diagnostic accuracy, because lots of things limit your walking. All right, like you might have an ankle sprain. So just that in itself doesn't mean much. It's all right. So, but is it useful to ask the question, is your walking distance limited? The answer is absolutely. And it is particularly useful for people who have stenosis. But it's also particularly useful for people who have vascular claudication as well. So they are really two different questions. So to answer your question more precisely, what are the most diagnostically accurate tests? There are a number, all right, that are good. Consistently, there are several that come out in the literature going way back, and that is a cross straight leg raise, positive cross straight leg raise test has very high specificity, very low sensitivity to a disc herniation causing nerve recompression, but extremely high specificity. In other words, when you see that, although it doesn't happen very often, it almost always is a very large disc herniation. So it has diagnostic value because of its high specificity, but it's not very sensitive and useless as a screening test, because 95% of people who have a herniated disc don't have a cross-leg straight leg syndrome. So in other words, it's not good as a screening test. So in other words, because of its high specificity, it's useful for when it's positive, but useless when it's negative. Doesn't rule out stuff. Okay. Another one is the exact opposite, which is the ipsilateral straight leg raise test. It's been well tested, along with the femoral nerve test, been well tested. Now it has exactly the opposite properties to the cross straight leg raise or cross femoral nerve test. And that is that it has high sensitivity but low specificity to a herniated disc. In other words, almost all herniated discs, not all, but maybe better than 90%, have some form of limitation of neural mobility, which provokes the pain. In other words, when you challenge it, it provokes the pain of which they complain. So it's highly sensitive, so it's very useful as a screening test. So diagnostic accuracy is, those two tests have been around a long, long time. Everybody knows them, everybody does them because they are useful, and they also have known diagnostic accuracy characteristics that we know of, and it's been measured many times. Another test, for example, is the one that's been around since the 80s, and that's the centralization phenomenon. Now, that centralization phenomenon, that's when you could cause the pain to move from a distal location to a proximal location with repeated movement testing. That has better than 90% specificity in relationship to the only criterion standard we have for discogenic pain, which is provocation discography, and it's discogenic. It's a 90% chance it's discogenic when a person centralizes. So we can do that in the clinic. This is not something that you need any special high tech or anything like that. It's very, very simple. Another high specificity test is a motor deficit, not a sensory deficit, but a motor deficit. All right, that has high specificity to prolapse discs. Okay, we know that 3 or more provocation tests have high specificity and really reasonably high sensitivity too, to the criterion standard of controlled blocks to the sacroiliac joint. If you, I mean, I know I'm responsible for that, so I keep on talking about these things, and I've done this myself. But when we were looking at this in the 1980s, it was very clear that, I mean, I was a McKenzie instructor and practitioner, and I was doing the repeated movement testing since the late 1970s. And there were people that I was absolutely convinced had sacroiliac joint pain, but they never centralized. They didn't seem to ever centralize. But I was convinced they had sacroiliac joint pain. And quite conversely, there were people who were centralizing. And we believed, we didn't know at that time, but we believed that was a discogenic phenomenon. It only happened to people with discogenic pain. That was the explanation for the centralization phenomenon. But those people often had positive sacroiliac joints. So we knew there were false positives. So the first thing we had to do was we had to go about finding out if these tests were reliable, and we did that. And then we went on to look and see if it's to compare the reliable tests to the reference standard, the criterion standard, and we found it to be highly specific. And what's more, our guess in the 1980s was very accurate. Right, more than 3 clearly that's the key number, but 3 or more was about right. It's exactly what we thought it would be. And also that if you interpret the sacroiliac joint provocation test in the absence of the centralization phenomenon, the diagnostic accuracy doubles, or nearly doubles. All right.
Could you tell us a bit more about how to perform those? So can I just quickly just say, so what I would usually do with an SI joint, and possibly that's where you could help me. So we were always taught kind of get your thumbs on PSIS, perform some flexions and extensions, and see if the SI joints are moving succinctly, so they're moving correctly, and then we might do some compressions and some distractions. That was kind of limited. That was kind of where we got to with SI joint. In terms of any provocation tests. So what could we do further to that? And what
well,
you
first of all, the motion thing is not a provocation test.
so just
That's a
looking for
motion.
SIJ dysfunction, sorry.
Yeah, but yeah, that's right. That's not the provocation test. The one of the again, there's a whole hour can be spent on just how we go about this. But the bottom line is we knew the limitations of the palpation tests in the 1980s. The first paper published on the reliability of tests were on the sacroiliac joint by Potter and Rothstein in 1985, and they found that the provocation tests had reasonably reliable, and the palpation tests were not. We knew that then. And that was our own experience. I mean, I was taught all those things that you were taught. I did my diploma in manipulative therapy in 1976. All right, and we spent 2 days on the palpation test run the Freddie Carlton book. Okay, we spent 2 days on it, just on the palpation tests, and for at least 2 years after that, I examined every patient of back pain with those tests. And one of the things that I learned when I was a student of Freddie's was that he would do the test and I would do the test, and we very rarely agreed. Now, I assumed, me being the student and him being the guru, that he was right and I was wrong. But then when I started to teach those stuff to my own students, they found exactly the same problem. They assumed that I was right and they were wrong. The bottom line is we can't agree with each other. And then Potter and Rothstein come along and say, "Hey, you're absolutely right, you can't agree with each other." Now, there have been one or two studies done over the last 30 or 40 years, and will occasionally show reliability just sneaks above the lowest possible threshold. But really, in the essence, if you can't agree with the next person who examined that patient, you don't know what the hell you're doing. All right? In other words, who's right, you or that other person? And the answer is you don't know. You're either both right, or you can't be both right, but you're either one's wrong or both are wrong. And you don't know which one is wrong if one of you is right. You see what I mean?
Yeah.
Any
Yeah.
unreliable test is out. It's gone. It's the first thing that has to be done when we're looking at the accuracy of our assessments. So that's why we went through this whole process. I went from being a manipulative therapist who was teaching that stuff, the forward bending test and the seated test and the Gillette test and the the out slips and downs, out flares and in flares. We did all of that stuff, anterior anomats and all that nonsense. It's rubbish. It is absolutely no evidence to support any of that. None. We should never be taught anymore. They were nice ideas. It has as much validity as humours and bleeding patients. Really, we have to stop that stuff. All right, and this is not a criticism. The point is, we have done all that work. Why they're still teaching that stuff beggars belief. That work that has been done and has been done well. All right, not just by me. You look at Peter van der Werf in the Netherlands. He did exactly the same study on the reliability and the validity of tests as I did. I've never met the man. I've corresponded with him by email after he published his own work, completely independently of me, and he got almost exactly the same results. That never happens, does it? When you have two different groups and you get almost exact. I even wrote a letter to the editor of the journal where he published his stuff to note the fact that what he got and what I got were so close as to be virtually indistinguishable. It's in the published record. That was back in 96. Sorry, when was it? 96, 97, I think. The Archives of Physical Medicine and Rehabilitation, something like that. Anyway, just PubMed it. It's all there. All right. So we put the palpation test to bed because they are actually a waste of our space. The provocation tests, they do have validity, but we have known since the 1980s that there are many false positives. So you have to account for the false positives. We know that people who centralize, for example, often have positive provocation tests. But as soon as the pain centralizes, they stop being positive. You think about that. You haven't touched the sacroiliac joint at all. You just got the patient to do extension or flexion or whatever combination. And the pain centralizes and then the test stops being positive. So in other words, somehow the disc, which is the 90% chance of being the pain generator when the pain centralizes, the disc somehow is either stressed by the sacroiliac joint provocation test because I stress them quite strongly. It's not a trivial movement. All right, and and with a young male, you have to push pretty hard. With young, more mobile females, you don't have to push as hard. But the point is, with young men, you have to push hard. Otherwise, you're not going to move those joints. They're the stiffest joints in the body, as you know. These trivial movements, they're not happening. Ben Sturesen from Sweden, he did the work on stereoscopic X-rays to show that the movement in the sacroiliac joint is no more than about maximum of 4 degrees of rotation, averaging about just under 2 degrees, and translation, which is separation, of no more than a millimeter. It doesn't move. It moves some, absolutely. But that big joint, it's one of the biggest surface areas of the whole body. Its total volume is 2 cc. There's not much in there. Not a lot of ligaments to move. It's a tightly bound thing. It's a shock absorber. It's not a joint to enable movement. It's a shock absorber. Anyway, we won't go into that, but that's not really answering your question. But the point is the whole sacroiliac joint thing, to me, that is old history. All right, that's settled. Now, is there more research to do? Absolutely, there is. All right, and I've been trying to get people to not only validate my work, but to actually criticize it and to try and refute it. And that has not been fully done yet. Right, and that still needs to be done. It's a matter of science. All right, science is all about proposal and refutation. Conjectures and Refutation. That's by Karl Popper. You might have heard that philosopher. That's his thing. It's falsification. So anyway, the point I'm making is that that's the sacroiliac joint. If we go back to the centralization phenomenon, that test is apart from the straight leg raise and femoral nerve tests and things like the sacroiliac joint tests, the centralization test is probably the most studied clinical test there is. All right, there's practically no other test. Oh, and sorry, the neurologic deficits. The loss of motor power and stuff like that. That's been well studied as well. But apart from those old ones, the neurologic deficits, straight leg raise, which go back way back to the early 20th century, really. The more modern, we have the sacroiliac joint has been properly studied, and the centralization test, if you want to call it that, is probably the most studied test there is. And that the results of the studies are not exactly universal, but they are very strongly in favor of that test being useful. All right. And why it's not taught in schools as a matter of undergraduate training beggars belief. Now, I have no axe to grind. I have not had anything to do with the McKenzie Institute since 1999. All right. To me, they're almost a competitor. Not really, but I mean, the point is that this is I have no axe to grind here. I'm only talking science, and the science says is that it's a reliable test when the instructors or the examiners have been trained properly. If they haven't been trained properly, they're not reliable. So you have to be trained to be reliable. And if you satisfy the criteria for centralization with a person who's been trained properly, then that person can identify one subset of discogenic pain. All right, so let's get away from that. What other tests, all right, are useful and valid? And some of them are on imaging. For example, if you see an extruded disc, now an extrusion is different from a protrusion, is different from a prolapse, and it's different from a herniation. An extruded disc means that the material outside of the disc is bigger than the hole through whence it came. Okay, that's the, if you like, the simple definition of an extruded disc. That it has a similar specificity to a large prolapse disc. If we see that on MRI, then it's going to be the cause of pain. All right, it's 90% of the time. All right, there are people who have these things that don't have any pain. That's true, but not many. All right, most do. All right, so that's one. The second thing is modic changes, and the third thing is high intensity zones. All modic changes and high intensity zones seen on T2 weighted images have very high specificity to provocation discography as well. They're about the same sort of diagnostic power of centralization. But, and this has not been established in the science, but where our own experience is that people who centralize often have modic changes, but people with motor changes don't always centralize. So in other words, we're talking about, so there's subgroups within the anterior column pathologies that can be identified by centralization, by imaging. Okay. And it's not just motic changes. If you see big defects in the end plates with motic change, what edema around the outside of it, they're often they're also pain producing as well, very high specificity. So imaging is helpful. And what's more, motic changes and high intensity zones do not cause leg pain very much. Somatic referred pain, but not radicular pain. So this idea that you should never do an MRI unless a person's got leg pain is rubbish. Not true. There is a time for the person who has persistent back pain and back pain alone, dominant in the back, for them to have an MRI. And they're not just crazy. They can have pain that goes on and on and on and on and on and on and on. All right. And they're not crazy. They're not psychosocial. Well, they might become that way. If you have pain that goes on and on and on and on, you do get depressed. All right. And anxious and stressed and all those things that we know about, which further accelerates and enhances the pain. Okay. So I've talked about the anterior column. We've talked about I divide the spine pathoanatomically into anterior column, posterior column, and the intermediate zone. The intermediate zone are for things like foraminal and central stenosis. Okay, those are the canals, if you like. The posterior column, right? You have basically only two common conditions. One is facet joint arthropathy causing pain, and the other one is pars interarticularis and other bony defects, and you can usually identify those just through history and fast bowlers and pitchers and gymnasts and people who are doing lots of loaded extension, basically, or high speed rotational forces. They get these stress reactions and stress fractures, and everybody accepts that these are painful. Not always painful, but when you see a fracture there in that person with the right history and they come in with back pain, you can guarantee that that's the reason. Not guarantee. Nothing's perfect, but it's close.
Yeah, and it's putting those things together, isn't it? It's that
Yeah,
combination of and the
absolutely. Yeah.
pain.
You just don't look at the imaging. No, the imaging is what you look at the patient, say this person looks like they've got a posterior. They'll almost invariably have unilateral pain. They have the right sporting behaviors, right? And you'll say this person has a very high chance of having a stress reaction or stress fracture. You don't have an MRI, and the radiologist goes, don't know. So then we now do VIBE. It's MRI with VIBE, it's called, and it has just as good a accuracy as CT scan in picking. And you can also, using VIBE, you can actually accurately measure how much it is repairing, which you can't quite do on a CT scan. CT scans give you a better picture, but they don't give you of the actual bony structure. But it doesn't give you as good a picture of the actual process, where in the healing process it is. So MRI with VIBE is particularly useful with that. And then we talk about the facet joint. Now, in 1998, there was a Frenchman by the name of Maurice Ravel, and he wrote a paper, and he had compared a whole lot of clinical variables to diagnostic blocks, 75% reduction of pain following an injection, and he came up with certain criteria, which we at the time called them Ravel's criteria. And this to me was the big gap. We had sacroiliac joint organized. We had at least one part of the anterior column sorted out, which was the mechanical discogenic pain, which is the centralizing people, right? And we could identify nerve root problems and stuff like that without any difficulty. But the one big hole in our assessment was the facet joint. And when that paper was published, I went, "Yay! We finally got some handle on our ability to diagnose, clinically diagnose facet joint pain. And I went and just started doing my PhD in 2001, and I included in all the patients, I saw 200 patients, and for 158 of those had diagnostic injections for the facet joint. And we wrote a paper published in 2004 where I specifically tested Ravel's criteria to see if we could falsify it. And we absolutely falsified it. At the time that I had set up my PhD studies, and one of the things that I was going to do was do this to test Ravel's criteria against in a different population. Another person had done exactly the same thing and actually published a paper before me in 2001. It was published, and it's Manchakanti. That's Laxamaya Manchakanti from Kentucky, and he had published a paper, and he'd also tested Ravel's criteria and found it to be useless. So 2001. Manchakanti found that the Ravel's criteria were no good, not validated, and we did the same. We published that in 2004 in the Journal of Musculoskeletal Disorders. And so the Ravel's criteria were out, gone. Two people have proved them not to be useful. It's out. And we set about to do our own study, and that study was published in 2006, and we found there were we took about 600 variables from the clinical assessment. I did a very large clinical assessment on 200 patients. So I had about 800 variables in my statistical model. It's a lot. And we systematically went through all of these on a 2x2 tables comparing the test positive or negative with the result from the injection. And we did the same thing with a 50% reduction in pain following the injection, 70%, 75, 80, 85, 95, and 100% reduction in pain following a block. So we tested each clinical variable against a range of pain reduction standards. And we found that there was no accuracy at all in under 85% reduction in pain. You have to have at least 85% reduction in pain before the model generated anything. And we found that, and I published 5 clinical prediction rules to predict the screening block. We didn't have enough double block patients to actually test the theory against people known to have facet joint pain versus those that we know do not. And so that was published in 2006, and not one single person in the world has ever attempted to challenge that. Despite my trying to help, I've got at least 10 people who said, "Oh, I'll do that," and they never did. And I've written them letters, and I've said, "Challenge it, challenge it, challenge it." That is how science is done. Nobody has ever done it. So at this point, we're now 20 years down the track, over 20 years, not quite 20 years. All right. Nobody has challenged my clinical prediction rules for the facet joint. And they're weak. They need to be challenged.
Maybe this is an idea for my dissertation.
Well, I will help you. If you want to do that, I will help you. By the way, there's a Frenchman in Paris who's actually in the process of looking at it as well. And I think it might happen there. But if you want to do it again, more than one's good.
Yeah.
And what's more, if you find that you don't get the same results as me, you may get better results. You might improve upon my work. That's great. That's what it's for.
Yeah.
So
Sorry, let me just turn that off. That's my I've got diabetes. That's my blood sugar alarm. Let me just turn that off. Sorry. Here we go. Sorry.
okay. So, all right. Now you asked me about which tests are good.
Yeah.
These are the ones we know about. Now, there are 1 million tests out there. And I have done practically every one of them over 55 years of practice. And I have progressively dumped them. Dump, dump, dump. You could spend a day examining a patient with all the tests that are available. And yet you've got to see enough patients to stay alive and to actually do any work that's worth doing. You have to limit what you do. That's practice. I've only ever worked in private practice. I've never worked in a public hospital, except for the first few months of being as a 20 or 21-year-old. So, I mean, I've only worked. So to earn a living, you've got to see enough patients to make a crust. And so I have progressively got rid of anything, brutally got rid of anything that doesn't do anything. Can't be proven. I mean, there are tests that I do that have not undergone um, adequate testing, but I'm convinced that there's value in them but they still need to be tested. But everything that's been tested, everything that I found to be unreliable in my own hands, gone. I was one of the first physiotherapists to do acupuncture. Did it for about 10 years. It's gone. Dry needling. It's gone. Completely unreal. You can never predict the outcome. You can't. All right. Trust me. I've tried for 10 years. All right. I was a teacher in manipulative therapy for 15 years. Manipulation has a role, but it's a small role. And Mackenzie himself said it very, very clearly. Why are we manipulating 100% of the patients in order to find the 10% that need it?
Very good point. Yeah.
It's good, it's a very good question. And he was absolutely right. And it may even be less than 10%. Okay. I still like to do it, but can I say that manipulation, how many patients in the last 55 years can I honestly say with a straight face that they got better because of manipulation and nothing else? Not many. A few, not many. Now, has it helped? Absolutely. In so many ways. Handling the patient helps. You know that. Everybody who handles patients, touch your patients, you move them, you put your arm around them, you massage them. These things are valuable for the patient therapist interaction and trust. That's really valuable, right? But just don't come into that touch thing with this idea that you're doing something special with your hands. It's really good to have good hands. I think everybody should be trained in a bit of massage and maybe some manipulation because it teaches you how to handle patients, how to actually physically handle them. I think it's a valuable skill, right? But we must not overemphasize its clinical value. That's how I see it anyway.
Yeah. No, and there's
So
and
what you
you
want to
see
move
it.
on to the next thing?
Yeah, yeah, yeah. That's fine. Okay, so you've already talked about this. So the next question was to talk about how accurately we can distinguish, and I think you've said that is that it's there are quite a lot of tests that aren't easy to distinguish between where we're actually testing.
Yeah. Oh, true. But again, no clinician, no expert clinician that I have ever met, and I have traveled the world quite widely, no expert clinician relies on a single test, ever. You have to build a hypothesis as to the diagnosis. I mean, I'll just give you a little example here. All right. By the way, my book, which will be published in the next month, all right, it's about 500 odd pages. All right. It's entitled The Science and Art of Musculoskeletal Diagnosis. That's its title. So it's going to be coming out in fairly soon. All right. But in this book, so I explained it in some detail, so I don't need to do much, but I'm just going to give you a little example here. Patient walks in the door. All you know is that your next patient's got back pain. That's all you know. Right? Or I won't even use back pain. Let's do shoulder pain. Doesn't matter. All right. Comes in with shoulder pain. And the first thing you do is you watch the patient take the jacket off. And they take it off easily. Have you changed your pre-test probabilities? Yes, you have if you're smart. Because the chances of that person having a frozen shoulder have just gone down. No person with a frozen shoulder can take off their jacket without moving in strange ways. So as soon as you eyeball that, you've changed the probabilities. Now, let's just say the patient takes the jacket off and they might wince, but the movement's fine, right? Then you ask the patient, so where is the pain? Oh, it's in my shoulder. Is that going to be a shoulder problem? No.
Oh, no.
The probability of it being a shoulder problem is actually quite small. In fact, it might be the AC joint, but not subacromial and not glenohumeral joint. The chances are that's coming from the neck, not from the shoulder. All right. So all of a sudden, just by those simple questions, you have changed probabilities quite dramatically. And diagnosis is Bayesian. I don't know whether you know the term Bayesian, the Bayes theorem. Bayesian probability manipulation is what expert diagnosticians do. They change probabilities. They don't talk about certainty ever. They talk about degrees of certainty. They talk about what's the probability this person has a rare condition or a common condition. For example, when a person walks in the door and they say they've got back pain, the probability this person has discogenic pain is about 40%. That's the pre-test probability because 40% of all back pains have discogenic pain. You put a disc in there, a needle in there, and you pump it up, and you can produce their pain. And you put it into an adjacent disc, and you pump it up to a very high pressure, and they say it doesn't hurt. You have a negative control, you have a provocation of the exact pain, right? There's about 40% of back pain patients actually have discogenic pain, and that can be proven. There's plenty of data. All right. About 15% of patients have facetogenic pain, proven by double blocks, controlled blocks, placebo control or some other control. Right? About less than 13% of patients have sacroiliac joint pain, as proven by diagnostic injection. So we know that when you have a patient, when you're in a chronic back pain clinic, those are the proportions. 10% are going to have radicular syndrome, 40% are going to have discogenic pain, 13% are going to have sacroiliac joint pain, and 15% are going to have facet joint pain, and the rest, if you add that all up, it comes to about 80 or 90%. All right? So that's what back pains are. The question is, now, when you start testing, how do you change those probabilities? Now, I'll give you an example. If the patient comes in and I do my repeated movement testing and I can't make those symptoms centralized, I can't identify a directional preference. Knowing that that's probably 50% of all discogenic pains behave in this way, then I reduce the probability of discogenic pain by half of the 40%, by 20%. And that 20% has to be distributed in what's left. So that 20% increases the probability of facet joint pain, sacroiliac joint pain, etc. See what I mean? It's called probability manipulation. It's not rocket science. It really, really isn't. And so the point is that the people who criticize diagnosis usually do so from a vast ignorance of diagnosis. Diagnosis is a very, very understudied science. It is a science in its own right. And the nice thing about it is that the mathematics is extremely simple. Even a mathematically challenged person like me can do it. If you can control an Excel spreadsheet, you can do diagnostic science. It is actually one of the most exciting frontiers in physiotherapy because the doctors aren't doing it. Now, in musculoskeletal medicine, it's up to people like us, physiotherapists, to actually push this ahead because the doctors aren't doing it. They're doing their little thing, diagnostic injections and imaging and stuff like that. All right, but they're not really doing the clinical stuff. There's a big gap there. Physiotherapists need to step into the gap.
Yeah.
Diagnostics is great.
Yeah. And I've heard people say kind of obviously it's as you get experience, it's becoming really skilled at just slightly changing those tests and how you can then kind of nuance it and start to find things.
No, that's the old manual therapy way. It's not true. It's not true. When we first did the sacroiliac joint reliability study, we started doing this in the very early 90s. Okay. And I had in my employ about 6 physiotherapists. And I was very liberal about how I taught them because I was already a teacher of both McKenzie and manual therapy at the time. And I'm very aware that I'm a large fella. big strong hands, and ex-athlete and all that stuff. And so, yet most of the people I'm teaching are smaller than me, less powerful than me, and female. So I had to accept the fact that they had to do it a different way from me. I could do the compression test just by using my pecs, but a woman can't do that, and most men can't apply enough pressure either, frankly. So we changed that, relying on their side and using their body weight. So there's just little things like that. But at the time when we first started the study, I just let them do. I taught them the test, and I said, "Now you just do it your own way, and whatever, and it'll be fine." Well, we did 10 patients, and we couldn't. The reliability really sucked. It was terrible. So I said, "Whoa, okay, stop. Now we're going to have some training sessions, and we'll work out a way of doing these tests that everybody can do, regardless of their size and power." Remember, it's the strongest joint in the body, and that's where the tests that everybody knows that I'm associated with came out of the fact that just letting people do it their own way doesn't work. It's not reliable. Okay, so but you don't have to be precise. You just have to apply enough force, and you have to vary the force according to gender and general physical uh, condition of the patient. I'm obviously a fragile 80-year-old woman you don't go bouncing around on, but and a young, fit young 30-year-old who's an athlete male, you can hammer them to hell and it won't make any difference. So you have to tailor the amount of force you use, but the actual technique, there are things that have to be done to make sure you get the right pressure in the right place, but it's not that difficult. You don't need golden fingertips.
Interesting. Yeah, thank you. Thank you for the tips. Um,
Yeah.
yeah, no, that's good. It's good. So with terms then that are used, like for instance, the term of non-specific low back pain, um, do you think that that is then just someone that's not able to diagnose? Is that a failure of diagnosis to say someone has non-specific low back pain? Is that just kind of a cop out?
No, it's not. Well, it can be a cop out, of course. Anything can be a cop out. But the patient walks in the door. They are at that point non-specific because you haven't done a diagnosis yet. So how much of a diagnosis you do depends on what you're prepared to do and how much you know and how much you actually seek to pursue that. If you have accepted the fact that there's no such thing as a good diagnosis, or we can't make diagnoses in patients who have back pain, for example, then you'll never examine the patient in a way that'll give you a diagnosis. So in other words, it's a self-fulfilling prophecy. Okay. So my goal as a clinician, right, who mostly only sees back pain these days, but I mean, I consider myself to be fairly complete in terms of the musculoskeletal system. My goal always was to try and find out what there are two things in a diagnosis that we look for. We want to know where the pain's coming from, and know what structure is the origin of the nociception. And secondly, we need to know out why is it painful? What is the cause of that structure initiating and perpetuating nociception? So structure and cause, all right? Where and why? Those two things go hand in hand. You might know that it is the meniscus of the knee, but is it torn or just inflamed? All right. You might know that it is your pain is coming from the facet joint, but is that just like osteoarthritic and stiff and not inflammatory, or is it an inflammatory condition? All right. Both have pain coming from the facet joint, but the cause of that facet joint being painful may be very different. Right now, very recently, our most recent paper published in January this year on the I don't know whether you've seen that one that's been published we did pre and post epidural injection on lumbar spines. It's published in the Journal of Musculoskeletal Science and Practice, the old manual therapy journal. That's just been published in January this year. And what we did was that we got patients to measure their back, buttock, and leg pain the morning before the injection, and then at 1 hour, 2 hour, 4 hours, 6 hours post injection, then 1 week later. Now, every one of those patients had radicular type symptoms, and they had a high risk of having radicular pain caused by a prolapsed disc or a herniated disc or protrusion. And the reason why we did this study is because I've been involved in managing patients with these having epidurals for many years. And we know that the responses to the injection are extremely diverse. There's no single, not everybody does well. Some people do brilliantly. Some people do brilliantly during the anesthetic period, but 1 week later they're just the same. Some people have no effect whatsoever. No anesthetic effect, no corticosteroid effect. So what we wanted to do is to try and capture this complexity, which is, and we found there are basically three broad categories. There's actually six categories, but we narrowed it down to three categories to keep it simple. And that is that there are people who get no anesthetic response in the 6 hours following the injection, because there's two drugs involved, right? You've got local anesthetic and cortisone injected. The anesthetic's gone in 8 hours, and the cortisone doesn't start until the next day. So in other words, you can, even though you inject two drugs at the same time, you can separate them out just through a matter of a 24-hour period. And 1 week later, the cortisone is having its maximum effect. So we always brought the patient back 1 week after the injection and got them to measure their pain again. And we found there were three categories. 21% of people found no anesthetic effect and no cortisone effect. 1 out of 5. All right. You have to read the paper. It's very simple. But the second group is anesthetic effect. Yep, the patient, we obviously injected the right level. But by a week's time, the pain's just come back again. No cortisone effect. It's clearly not inflammatory. We injected the right level, but it's not inflammatory, because if it was inflammatory, the cortisone would have killed it. Stops the pain. Cortisone is very powerful. Okay, on inflammation, nothing else. Right, and it does affect your insulin as well. But that's another issue. Right. Then they have the other group, which is the largest group, about 41% of people, who had both a very significant anesthetic effect and a significant effect at 1 week. Still much better at 1 week. So it's clearly inflammatory. So there you have a known condition likely to be a nerve root condition. Something like 60%. We obviously got the injection in the right spot because we had an anesthetic response. And the cortisone was only effective into 41%. So you have the same condition with two different causes. One's inflammatory, the other's probably mechanical, just pure pressure and tension on the nerve root. Right? So, and it's the same. Take tennis elbows. Just tennis elbows. Anybody can diagnose tennis elbows. It's a piece of cake. It hurts there, and it hurts when you do that. How many people with tennis elbow does that not happen? How many people who have that pattern who don't have a tennis elbow? Not many. It's a really easy diagnosis to make. All right? You try this. Don't have to believe me. You try it. Very simple thing. I did this in the 80s. We used to see lots of tennis elbows. All right? You do that and do resistance, and they go, oh, yes, that hurts. But don't stop there. Do it 10 times. Pressure on, pressure off. 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 Do you know there are 3 different categories of response? Ah. One group, oh, that hurts. And the more they do, the better it feels. Well, that's no longer hurting by the time we get to 10 or 15 movements. Another group, by the time they get to 5, they're going, oh, shit. Oh, man. And you trash them for 2 days. All right. And the other group, just the same, just the same, just the same, just the same. So which one's inflammatory?
One that's screwed up for days.
And what do you think that is?
The
just the
mechanical.
same.
Yeah.
Well, you can call it mechanical, but it's obviously probably just scar tissue within the tendon but it's not inflammatory. And the one that gets better, that's an interesting one. And I have a hypothesis about that, but it doesn't matter. The important thing is that there are subcategories of each one of these conditions. And what's more, the treatment is predicated on what it is. For example, if you take the person who has an inflammatory response and you tell them to go away and do that, they will never, they'll stop doing it and they won't come back. Goodbye. You're out of here. I'll go and see the chiropractor. I'll go and see an acupuncturist, or I'll go and have an injection or something. You know what I mean? All right. The person who is the same with every time, if you don't give an explanation, they will stop doing it too because it's not getting better in a week. Because it takes about at least 6 weeks to change. But you have to know that. You have to know that it takes 6 weeks to change. You tell them that. You've had this for 2 years. Now you have to go and start remodeling that tissue. Keep going, keep going. It'll get stronger, it'll get stronger, it'll get stronger, and you have to push harder before the pain comes on, etc., etc., etc. That's fine. Now, the person who gets better, the 10th one is much less painful than the first one you did. If you do too many, you'll trash them and they'll turn them into an inflammatory response. But you try it. You don't have to believe a word I say. But to criticize me, you have to have tried these things, and I have done that. All right, on a variety of different things. And so we know what the tissue is, but is it inflammatory or is it mechanical? Two different types, at least two different types. All right. We don't know what the third one really is. Okay. So yes, diagnosis is two parts: identifying the tissue source of nociception and then identifying the cause of that nociceptive response of that tissue. Very important.
Yeah. No, that's brilliant. I like it. Um, so I'm going to skip that next one because I think we covered that. That was really good. So talking about how things can be misleading. So I think you covered that really well. This one's a little bit more controversial. So I know you wouldn't be shy away from a bit of controversy. So is there anything that's currently done in the physiotherapy practice, and if we keep it specific to low backs or backs in general, is there anything that's done that you would love to see the back of and get rid of?
Funnily enough, not really. What bothers me is not the fact that people do things that I don't agree with. That's not the issue. I mean, I've done acupuncture to backs. I did it for 20 odd years, and and so it's hard for me to say, oh, you should never do that. Hell, I did it for 10 years, 15 or 20 years, whatever, however long I did it. All right, and I've stopped doing it because in my hands, at least, it was unreliable. Sometimes you get great results. Other times, a case. I'll give you one really good example. Now, there's one condition in the shoulder which Siriax described back in the 50s called acute subdeltoid bursitis. And the patient, it's a very characteristic presentation. The patient comes in and they will say, oh, I've got this terrible shoulder pain. And I can't lift my arm at all. And it happened 2 days ago, suddenly, for no apparent reason. They can't lift their arm at all. And they're in agony. And he would go in there and he'd do back in the 50s, he'd do just a procaine injection. And in the 60s, he started doing cortisone injections. And they do very well with the injection, actually. But when I was doing acupuncture back in the very late 70s and early 80s, there was a guy, a doctor in Auckland, New Zealand, Gerald Gibb was his name. And he'd been to China and he'd learned all acupuncture and all that sort of stuff from the Chinese. And he came back and he was teaching doctors and physiotherapists how to do acupuncture. And I was one of them. And I saw him, he had in those days, we didn't have video and cameras, but there was a movie that he had managed to take of a guy who clearly had what we would have called acute subdeltoid bursitis because his sudden onset of acute severe pain, constant pain, can't sleep at night, breaking his sleep, terrible pain, couldn't lift his arm. And he put a needle into the stomach 36 at the front and the bladder 54/7 at the back, and he put the needle right through the anterior thing, right between the tibia and the fibula, right through till you can almost see it protruding out the back in the calf. And he did that for 45 minutes. And after 45 minutes, this guy's doing this. No pain at all. And I'm going, that's cool. That's really cool. I mean, I watched the video, or just a movie it was at the time. And I thought, "Oh, I can do that. I don't have a pretty problem sticking needles in people." So, but as it often happens, you go back to the clinic, and guess what? Within a week, I had a person with acute subthalatal bursitis come in. I said, I want to try something with you. So I stuck a needle in the front. I didn't have a long needle. I only had the short ones. I put one in the front and one in the back. And I spent there 45 minutes doing this. And bugger me if he couldn't lift his shoulder at the end of it. Well, that's cool. This patient doesn't have to have a cortisone injection. Because although I was doing cortisone injections occasionally and teaching doctors how to do them, wasn't doing them routinely because we don't prescribe and all that sort of stuff. So I thought, well, this is a good thing to do. If I That's only 45 minutes of that, the guy can lift his shoulder again. And then about a month later, another patient comes in with exactly the same thing. I said, boy, have I got the treatment for you. 45 minutes, not the slightest change in the least. No different. And that was an exact, that happened so many times with acupuncture, right? That you get great result, and then what appears to be exactly the same condition, you wouldn't. Now, go figure. Now, be it acupuncture, be it manipulation, be it core strengthening, be it, I was taught Yanda system, which is now Shirley Salmon and the sort of the various groups get tight and other groups get weak and stuff like that, and muscle groups. It's all about muscles and balance between agonists and antagonists and things like that. I was taught the Yanda system. And so there are people who do all those sorts of things. And unquestionably, they get good results. All right. But the question is it repeatable and reliable and consistent? And does it have a good explanation? The answer is no. Do chiropractors get good results sometimes? Absolutely, they do. Do osteopaths get good too sometimes? Absolutely. You go to Sweden, they've got the naprapaths. All right. Well, they're just a mixture of chiropractic and osteopathic, I suppose. That's a Scandinavian version of the chiropractor osteopath. You know, and do I think what they do is wrong? Well, yeah, I do, but I wouldn't want to stop them. They're helping people. I mean, I know chiropractors who are actually really, really good at what they do, and they're really good with patients, and they help people, and they try to make them independent and all that stuff. I know some excellent chiropractors and osteopaths. So I have no axe to grind about what people are doing. The only axe that I have to grind is don't confuse patient care with science. We want to base our care on as much science as we've got, but we don't have all the science. The science is extremely immature. So you have a choice. You either accept diversity in what people do with patients, accept it. Or you want to start bullying people into not doing things or doing it your way. And I don't approve of that. After all, I am a libertarian. So you know what I'm saying. The point here is that if we want to do science, let's do science. That to me is a passion. All right. But do I want to change people? Of course I do. But I want to change them in a way that makes them think better about what they're doing, about challenging what they do. Be prepared to stop doing stuff that's not working even in your hands. If it's not working in your hands, why are you doing it? If there's nothing you do that makes you feel as though you're helping people, get another job. You know what I mean? Um, so no, there are many things that I have tossed out because they don't work in my hands, at least. And what's more, my experience has been is that other people have found the same thing.
Oh, that's good. That's a good answer. And yeah, that's perfect for if what you're doing is not working, then yeah, you shouldn't still be doing it. So that's good. Um, what would you like to see more of? So in clinical practice, is there anything that you think people should be doing more of?
Yes. Um, One of the things that, as I say, I haven't had anything to do with the Mackenzie Institute for a long time now. But one thing that I find is disturbing is that there is not only a cultish, there is a there seems to be a desire amongst physiotherapists at least, and to some extent doctors too, to be engaged in some sort of identity identification with some guru or something. And I've been influenced by a number of different gurus, you know, the Alan Stoddard, the osteopath, Jeffrey Maitland from Australia, Brian Mulligan, and Robin McKenzie, obviously. I've been influenced by medical practitioners, most notably people like Nikolai Bogduk, whose work in science and pathoanatomy is unparalleled, really. I was very fortunate to meet a guy called Dr. Charles April, was an interventional radiologist in New Orleans, and he was probably one of the early first teachers of proper diagnostic injection and technique. He does discography and all those complicated things, and he was a teacher in it. And I met him in 1995, and I started going to his clinic in 1996, and he's the guy I did all um, my research, my diagnostic accuracy research with. And I learned science from people like Nikolai Bogduk, from people like Charles April, and a number of other people as well. And one guy who was actually a good friend. I played golf with him twice a week for probably 15 years, and he was a statistician. I learned a lot from him. He taught me most of the stats I know, actually. And so I learned a lot of the science, I've always been passionate about science, and I did papers in philosophy of science back in the early 80s. So I've always had a passion for it. And but the thing here is that you might want to be a scientist, and I do, and I like being a scientist, but I am first and foremost a clinician. I've never had a full-time position in a university ever. I have worked for universities, and I was involved in the Auckland University of Technology in the stats department. I was there teaching people how to design their research projects, and I was also I was the supervisor for two PhDs as well on diagnostic accuracy. And so, but I've never really been an academic. I might have 40 plus papers published, but I've been a clinician all my life. And to me, patient is everything. And I see no value in wasting my patient's time with stuff that is unlikely to work. There's an enormous amount of value in developing a really good um, not close, but not too close. You know what I mean? Relationship, this therapeutic relationship between the patient and yourself. And I like to feel as though people are not intimidated by me. I don't mind intimidating my colleagues, but not patients. Well, I mean, the point is that if you can't stand the heat, get out of the fire, right? That's what science is about. We mustn't be silly about this. Is that people stand up and spout absolute nonsense, and somebody has to call them out. Otherwise, they keep on believing it, and other people believe them because nobody else challenges them. Science must be challenging, all right, but not in the clinic. The patients are special to me anyway, and I like to give them the best opportunity to look after themselves and take care of themselves as much as they can. By the way, most people don't, well, these days probably don't understand that, but Mackenzie actually invented self-treatment. They talk about it all the time, but they very rarely ever recognize the fact that Robert McKenzie was the first person to state clearly, unequivocally, that why are we doing things to people when they can do it for themselves? And the reason he gave for getting people to do things for themselves was exactly the right reason. Is that why do they have to keep on? Well, I'll tell you the story. I was only in practice for about 2 years when I first met Mackenzie, and I was already, even though I was only in my early 20s, I was already a skilled manual therapist, manipulative therapist, and I could manipulate pretty much any joint, so it wasn't a problem. I used to like doing it as well. And Mackenzie was teaching Mackenzie. No, he wasn't teaching Mackenzie. He was teaching manipulative therapy. He wasn't teaching his own stuff. And so after I started doing the course, he said, Mark, he said, let me ask you a question. This is what Mackenzie asked me. He says, um, I want you to go back to your clinic and look at your appointment book for tomorrow. This was on a Sunday. And I want you to look at your appointment book and tell me what percentage of patients on your books tomorrow are patients you've seen before for the same problem. And I thought, oh, okay. So I go back. Now, you've got to understand that we're talking about the early 70s here, mid 70s. And I found that 50% of my patients I had seen on a previous occasion for exactly the same problem. And I was proud of that. This may sound weird today, but back then, that was proof to me that, first of all, obviously, the patients came back because I helped them. And they obviously liked me. It was a very positive experience. And so I rang him up. Now, Mackenzie didn't live in Auckland. I was in Auckland. He was in Wellington. So I rang him up. Not a cheap thing to do back in the mid 70s. I called him. I said, Mackenzie, you asked me how many patients. I said, about 50%. He says, just goes to show, Mark, you're not doing well. And I go, what? He says, Mark, you obviously didn't fix them the first time because they come back for the same problem. It was like a slap in the face. Slap in the face. Honestly, I'll go, whoa. He says, Mark, what we should be aiming to do is to empower our patients to look after themselves so that they ever get the same symptom. If you could teach them how to take away their symptoms today and they get the same symptoms in the future, the chances are the same thing will help them and they will be able to look after themselves for the rest of their lives. Now, that's a revelation. It was to me. It should be to everybody else. Now, that was in the mid 70s. Everybody else was just doing stuff to people. Nobody was thinking about the fact that back pain, especially, is a highly recurrent disorder. All right. And that's one of the features of back pain, isn't it? Now, can we control recurrences? Well, the answer is actually no, we still can't. All right. Now, our success rate in actually reducing recurrence rate is not that good. It's better than it was, but it's not as good as you'd like. So, that's where I come from. I'm a clinician, first and foremost. My science is, I consider myself to be a clinical scientist, not an academic.
Yeah, no, that's great. And so really to wrap up, I really love that sentiment, and that kind of covers my question that I was going to ask you about advice to a student. So someone just starting out in the industry, what would your advice be? And from that, I take it that to try and empower your patients, to try and give your patients some
Sure.
ownership.
Look, yeah, there's many ways to do this, right? For example, the work by Peter O'Sullivan is great. The cognitive functional therapy approach. It's that I mean he's rebranded cognitive behavioral therapy to cognitive functional therapy, and he's done an excellent job. And he's dealing with patients who may have been on the books for a long, long time, and they've been scared of moving and all those sorts of things. And so his approach is about empowerment, absolutely. And I have a lot of time for Peter. Peter, by the way, is one of the few people in academia who has actually listened to his own results. he was back in 2000. That's 25 years ago now. He was known as the guy who did all the research in spinal instability, particularly people with spondylolisthesis. Most people don't realize that. He was the guru in that area. And he changed because he actually read the research and found out what are the predictors of a poor outcome. And they're nothing to do with whether they've got a spondylolisthesis or not. So he is one of the few people who have actually looked at what they do, the manual therapy they've been taught, the exercise therapies they've been taught, and all that stuff. And he found out that his success rate actually wasn't that flash. That's why he changed. Now, I wouldn't have changed in that direction. Frankly, being a person's counselor bores me to tears. I like the pathoanatomy, but that does not mean to say that in any way that I would minimize what Peter does, because he's outstanding. All right, but that, but you can't ignore the pathoanatomy either, because you ignore that at your peril. Now, I've just been an expert witness on a case this morning. The patient who's had back pain for years, and he is a distressed individual. He's an ex-con. But he's intelligent, and he's trying to turn his life around. And he's got this chronic bloody back pain, and he's got a small amount of nociception going on, which is being wound up by all the stresses on his life, which are huge. He can't get a job because he's an ex-con and all that stuff. There's lots of things going on in this guy's life. But with me, he's dead straight. He never shied away from the fact that he had spent time in prison. He never shied away from the fact he's got depression. We could talk about it, right, man to man, mano a mano type stuff. No problem at all. All right. But the insurance company here in New Zealand is taking him off the scheme because apparently his back pain should have healed by now after 2 years. And my question to the person at the Accident Compensation Corporation was, and you know that how? How do you know that it's healed? Well, he was given a diagnosis of a back sprain. So sprains get better, don't they? I said, you think that's a diagnosis? You see what I mean? To me, patients are being bullied by bureaucrats and politicians and physiotherapists and doctors with the science they don't understand. All right. And most of the time, the people doing the bullying don't understand the science either. They don't. So it's been interesting. I mean, I'm retired from the clinic last year. I'm now I'm a writer and still doing research, but so at 75 you've got to give it away eventually. But the important thing is that's my life, is with the patients. I still go and do these things for patients because that's been my thing.
Yeah, putting the patients first. No, that's brilliant.